Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's November 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlights articles. Our Editor's Choice is a thematic review on women's health entitled State-of-the-Art Diagnosis and Treatment of Hypertension in Pregnancy. It is authored by Drs. Laura McGee and Peter van Daleson from King's College London, United Kingdom. Hypertension complicates up to 10% of pregnancies worldwide. Pregnancy hypertension is defined as a systolic blood pressure greater than or equal to 140 millimeters of mercury or diastolic greater than or equal to 90 millimeters of mercury, based usually on measurements in office or clinic settings and using a wide variety of blood pressure devices. The hypertensive disorders of pregnancy are generally classified into the following categories: chronic hypertension diagnosed before pregnancy or before 20 weeks of gestation, gestational hypertension diagnosed at or after 20 weeks gestation, and preeclampsia, defined restrictively as gestational hypertension with proteinuria or broadly as gestational hypertension with proteinuria or an end-organ manifestation consistent with preeclampsia. Absolute blood pressure values greater than or equal to 140 over 90 millimeters of mercury are associated with elevated maternal and perinatal risks, particularly with preeclampsia. Other subtypes of hypertensive disorders of pregnancy include white coat, mask, and transient gestational hypertension. The following considerations merit emphasis. First, these classifications are fluid, not fixed, in that patients with chronic hypertension may develop gestational hypertension or preeclampsia. Second, preeclampsia is a subtype with the highest risk of complications, and its management mandates more than antihypertensive therapy and requires interspecialty collaboration. Third, blood pressure values greater than 160 over 110 millimeters of mercury, severe hypertension, constitute a medical urgency. Fourth, severe hypertension and non-severe hypertension are not separate entities, but rather lie along a spectrum of blood pressure values. Fifth, for the mother, any degree of hypertension is associated with more severe adverse outcomes in virtually any organ system, such as pulmonary edema, acute kidney injury, CNS complications including stroke. Sixth, for the fetus and newborn, hypertensive diseases of pregnancy are associated with stillbirth, neonatal death, and morbidity of varying severities. This review discusses in detail antihypertensive therapy of the hypertensive disorders of pregnancy as a specific management strategy. This includes the treatment of severe hypertension, defined as a blood pressure greater than 160 over 110, using such approaches as nifedipine capsule or tablet, parenteral hydralazine or parenteral labetalol, and the rate at which blood pressure should be lowered. In this regard, it is generally advised that blood pressure be reduced to non-severe levels over hours without reducing blood pressure more than 25% initially, with gradual lowering of blood pressure over the following hours. The rationale for this is that the fetal-placental unit does not autoregulate blood flow, and thus may be at a risk for underperfusion if blood pressure is lowered too rapidly. For non-severe hypertension, management approaches based on oral methyl-dopa, labetalol, or nifedipine are discussed, as well as salient issues pertaining to other classes of antihypertensive agents, including ACE inhibitors, ARBs, and diuretics. Issues also covered include those pertaining to antihypertensive management in patients prior to pregnancy and in early pregnancy. Therapeutic management in this review is rounded out by the discussion of the use of magnesium sulfate for the prevention or treatment of eclampsia, the use of corticosteroids for fetal pulmonary maturity, and corticosteroids and platelet transfusions for the HELP syndrome. Along with such specifics, this thematic review addresses the need for accurate measurement of blood pressure, agreed upon classification of pregnancy hypertension, agreed upon blood pressure thresholds for enhanced surveillance and antihypertensive therapy, and collaborative teamwork in the management of patients. Challenges in formulating management recommendations relate to the methodology of studies upon which care is based, as well as aspects of the care itself, particularly the unregulated use of home blood pressure monitoring. This review concludes by delineating areas to be addressed by future research, and this includes guidance for nuanced care as women transition between severe and non-severe hypertension, personalized antihypertensive therapy, and incorporation of women's values into research priorities and clinical practice when antihypertensive care is chosen. Our first highlight article is an original article entitled Physician Burnout, Well-Being and Work Unit Safety Grades in Relationship to Reported Medical Errors. This article is authored by Dr. Daniel Tawfik and colleagues from Mayo Clinic, Rochester, Minnesota, Stanford University School of Medicine, California Perinatal Quality Care Collaborative, Palo Alto, California, and the American Medical Association in Chicago, Illinois. Medical errors are common in the U.S. healthcare system and continue to remain prevalent despite widespread quality improvement initiatives. Serious non-fatal medical errors occur at 10 to 20 times higher rates as compared with fatal errors. Burnout and poor well-being have been recently recognized as common occupational hazards among healthcare professionals. The objective of this study was to evaluate physician burnout, well-being, and work unit safety grades in relationship to perceived major medical errors. From August 28, 2014 to October 6, 2014, the authors conducted a population-based survey of U.S. physicians in active practice regarding burnout, fatigue, suicidal ideation, work unit safety grade, and recent medical errors. Multivariate logistic regression evaluated the associations among burnout, well-being measures, work unit safety grades, and medical errors. More than 6,000 physicians in active practice provided information on areas of interest. 54% reported symptoms of burnout, 33% reported excessive fatigue, and 7% reported recent suicidal ideation, with 4% reporting a poor or failing patient safety grade in their primary work area and 11% reporting a major medical error in the prior 3 months. Physicians reporting errors were more likely to have symptoms of burnout, fatigue, and recent suicidal ideation. In multivariate modeling, perceived errors were independently more likely to be reported by physicians with burnout or fatigue and those with incrementally worse work unit safety grades adjusted for demographic and clinical characteristics. The authors conclude that in this large national study, physician burnout, fatigue, and work unit safety grades are independently associated with major medical errors. Interventions to reduce rates of medical errors thus must address both physician well-being and work unit safety. The second highlight is a brief report entitled Long-Term Weight Loss and Metabolic Health in Adults Concerned with Maintaining or Losing Weight, finding from the NHANES study. This study is authored by Dr. Gregory Nell from the University of Texas Health Sciences Center at Houston, Texas, and colleagues from the American Cancer Society in Atlanta, Georgia, the Michael and Susan Dell Center for Healthy Living, and the Dell Medical School in Austin, Texas. More than 2/3 of American adults are overweight or obese, with many attempting to lose weight to avoid adverse health outcomes and improve well-being. Achieving long-term weight loss success, defined as reaching at least a 5 to 10% weight loss goal, is challenging, yet important for overall metabolic health. It is currently unclear whether achieving higher thresholds of long-term weight loss is associated with improved health. The purpose of the present study was to examine the association between metabolic health and long-term weight loss thresholds in specific ranges that include 5 to 10%, 10 to 15%, 15 to 20%, and greater than 20%. Metabolic health was assessed by metabolic syndrome and metabolic risk Z-score. The metabolic risk Z-score is a continuous measure of metabolic health. The analysis involved almost 8,000 respondents to the National Health and Nutrition Examination Survey 2007 to 2014 who were overweight or obese, past or present, were not underweight in the past year, not pregnant, and attempting to lose or maintain weight. Multivariable regression models were constructed, adjusting for covariates. The basic findings indicate that among this population-based sample of historically overweight or obese individuals who aim to lose or maintain weight, successful long-term weight loss greater than 5% is associated with a more favorable metabolic risk profile. The results additionally indicate that although an incremental pattern was not clearly apparent, reaching the 15% long-term weight loss threshold is associated with even lower odds for metabolic syndrome and a lower metabolic risk Z-score. When considering all the individual components of the metabolic syndrome, all levels of long-term weight loss were associated with a lower likelihood of dyslipidemia. The authors conclude that although achieving the currently recommended long-term weight loss target associated with improved metabolic health, 15% long-term weight loss was associated with a more favorable outcome. The third highlight is an original article entitled Frontal Fibrosing Alopecia in Women, the Mayo Clinic Experience with 148 patients, 1992 to 2016. The study is authored by Mr. Reese Imhoff from Mayo Clinic, Rochester, Minnesota, and colleagues from Brown University, Providence, Rhode Island, and the Surgical Dermatology Group in Birmingham, Alabama. Frontal fibrosing alopecia is a primary lymphocytic cicatricial alopecia that is characterized by progressive recession of the frontotemporal hairline, often including eyebrow loss. First described in 1994, this condition is considered to be a variant of lichen planopilaris. The objective of this study was to characterize the clinical pathologic findings, comorbidities, and treatment outcomes of women with frontal fibrosing alopecia. The study involved a retrospective review of women with frontal fibrosing alopecia at Mayo Clinic from 1992 to 2016. The terms alopecia, lichen, planopilaris, fibrosing, and alopecia were utilized for the search of female patients aged 1 to 100 years. A total of 686 patients were reviewed to confirm the diagnosis of frontal fibrosing alopecia. Patients were included if they met diagnostic criteria. This study is one of the largest single-center retrospective analyses to date of this condition. The results indicate that 148 women with frontal fibrosing alopecia were identified with a mean age of 62 years. Approximately 60% presented with eyebrow loss. 68% and 28% described preceding or concurrent pruritus and trichodynia respectively. 45% had a history of hypothyroidism, 13% a history of surgical menopause, and 63% had a history of hormone replacement therapy. 18% had lichen planus at other body sites. 26% achieved disease stabilization, often requiring combination therapies. The mean time to remission was almost 2 years. The authors conclude that patients with frontal fibrosing alopecia typically present with frontotemporal and eyebrow alopecia, often with preceding symptoms. Hypothyroidism and a history of hysterectomy may be more common than previously reported. Time to presentation, diagnosis, and stabilization is often months to years. Patients who lack treatment response may present with eyebrow loss, eyelash loss, and facial papules. Combination therapy, as presented and discussed in the present study, is helpful in achieving slowing of the disease progression or stabilization of the disease, although recurrence is common. You can access these highlights and editor's choice articles free of charge during the entire month of November when you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org. You will see other free content and articles published online ahead of print. You can also find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find other author interviews, 60 seconds video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page, as well as through iTunes. You'll also find our Pioneers and Legends video interview featuring Dr. James Dick. And finally, our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.